Hello everyone, welcome back to Dr. Deepa's Learning Launch. Today I want to take you through a rare and memorable case in my diagnostic practice. Something that looked completely innocent first but later turned out to be a true surprise. So there was a patient who was 45 years old who presented into the clinic of an ENT surgeon, and he presented as a simple nasal polyp. Yes, it was a routine nasal polyp on endoscopy that concealed a clonal plasma cell neoplasm driven by EBV. Now, I'll tell you the whole story how it unfolded. The patient came to ENT with a typical symptom of nasal blockage, recurrent sinusitis, a polypoidal mass in the nasal cavity. Clinically looked like an ordinary inflammatory polyp, but there was not a hint of neoplasm grossly. The tissue came to me again labeled as a simple nasal polyp, but all of us know sometimes routine cases are the ones that test our vigilance the most. When I began screening the slides, this is what I looked at. The stroma initially looked like any other inflammatory polyp in the beginning, but as the cut sections were taken deeper, the edematous tissue and chronic inflammatory cells were way beyond what was expected. I noticed something that made me stop. Certain areas had dense sheets of plasma cells that were not looking reactive. They had eccentric nuclei, clock face chromatin, a prominent HOF, and occasional atypical forms. At this point, my differential included a reactive plasmacytosis versus plasma cell rich chronic rhinosinusitis versus extracellular plasmacytoma. So I decided to dig deeper into this and concluded with my IHC panel. The plasma cells showed strong CD138, CD38, clear light chain restricted, and this was kappa restricted. And this already pointed towards a plasmacytoma, and it was truly not negative because of clonal selection. But I wanted to understand why plasmacytoma would arise in a nasal polyp. So it led me to check the EBV status. The EBER in situ hybridization came back positive, and at that moment the whole picture fit together. A clonal EBV driven extramedullary plasmacytoma arising from a simple nasal polyp grossly on the clinical diagnosis. A diagnosis that you rarely encounter, but that's something that should never be missed. It was also important for me to rule out other possibilities. Before confirming the diagnosis, I ensured that no feature of NK cell lymphoma was seen in this, no angiocentric necrosis, no atypical lymphoid infiltrate, negativity for CD20 and cyclin D1, and clinically the patient had no systemic myeloma. So when you diagnose an extracellular plasmacytoma, you must make sure that you don't have any underlying systemic myeloma, especially if it is an elderly or middle-aged patient. We also recommended a CBC, calcium renal profile, SPEP, UPEP, a PET CT, bone marrow evaluation, and all of these came unremarkable, confirming that this was a localized EBV positive plasmacytoma. When coming to the management of what the ENT surgeon had done along with the oncologist, extramedullary plasmacytoma usually respond beautifully to local radiotherapy. So this patient was no exception to the same. The ENT team had excised the lesion completely. With appropriate follow-up, the prognosis turned out to be excellent. The patient remained disease-free for the next 5 years, and the later follow-up was done by the clinician. This case reinforces how the simplest specimens observe some meticulous attention and turn out to be a complex one. So the key takeaway from this case was nasal polyp with dense plasma cell infiltration deserve a careful second look, because it is always important to evaluate monoclonality when the morphology seems to be completely monotonous. The EBER-ish can consistently shift your diagnosis, especially if the patient is immunocompromised. So, even rare entities like EBV positive plasmacytoma can hide within common looking lesions. Systemic workup is definitely essential to rule out multiple myeloma. So, as closing thought, this case reminded me why pathology demands both science and intuition. It is not just what means the eye. That's what we question, that's what we pursue, and that's what we verify. Thank you for listening to this case-based discussion with me, Dr. Deepa, and I hope you enjoy learning from me. Stay tuned with Dr. Deepa's Learning Launch for further such videos, and don't forget to like, subscribe, and share my videos. Your likes and your comments are the ones that keeps driving me to teach you more and travel with you in this learning journey with Dr. Deepa's Learning Launch. Bye bye for today.